Now coming on to how to diagnose a fracture. If a patient presents to you with a deformity, or if there is swelling of a hand or a limb and the patient is unable to move his or her joint, then how to diagnose it? We will briefly going through the local signs, the X-ray and special imagery we may need, and what are the shapes of fracture and displacement we need to consider when especially dealing with the fractures. So what are the local signs? This could be, local signs could be, first of all, the patient would usually have a history of some kind of a trauma or a fall, or there would be definitely some kind of history would be donating that the part of the patient is complaining is probably had some kind of a injury to this area. This could be in form of a crepitus or abnormal movement. Crepitus means that the underlying fracture of the multiple fragments which get pressed when we press it from the top, and this results in form of a crepitus which may be very painful. Usually it's unnecessarily painful, so we have to be very look out for when we are examining the patient. Then usually the local signs could be simply swelling as well. If there is swelling, there is crepitus, and patient is unable to move that limb or that part of the hand. For example, patient had a fall on outstretched hand resulting in a distal radius fracture. Now when the patient will come to you, whether it will be swelling of the wrist joint, definitely the finger movement will be either painful, or the patient will not do that kind of a movement. And then when we will press it over the wrist joint, this would usually elicit a pain. So when we are dealing with this, most likely shows that there is definitely some kind of a distal radius fracture. We need to get X-rays first. X-rays are more diagnostics because bone is clearly visible on the X-rays, and usually the fracture line appears black and the bone appears white on the X-rays. Systemic approach is important when we're dealing with the fractures, and that actually approach is look, feel, and move. You look at the patient and you try to assess probably what could be wrong. If the patient says, I had a fall on the outstretched hand on the right arm, and he is holding his elbow, the most likely the most injured person could be probably the elbow joint, not could be the wrist joint, not somewhere else. Then you test for the artery nerve damage. You examine the patient, look, you feel the patient, and then you try to move the patient as well. When we are feeling the patient, we look for arterial nerve damage as well, and then for the associated injuries as well. And moving means look for the other associated injuries in the distance part as well. So you start with the look, you look at the joint involved, look at the joint above and below, whether there could be associated problem as well, and you look for nerve injuries as well. If the patient is unable to make an OK sign or unable to do these kind of movement, probably there's some degree of nerve damage as well. But at this moment, your priority is to first start with a look, then you go for the feel, and then you move the arm to see whether the fracture is present or not. Now coming to the local signs. Local signs would include swelling, bruising, and deformity. There could be an open injury. If open injury, this is kind of an injury is very classically high energy trauma, especially in the case of the femur. If you see this, probably there is very much visible that there is definitely an open, comminuted, and contaminated femur fracture, and we need to do something about this. Probably in this case, you are not sure whether it is associated with bony fracture or not, but if there is swelling and patient is unable to bear weight, and usually on examination you see there was history that something got hit on this area, probably on the malleolus, then yes, you should be suspecting fracture. But usually there is some degree of swelling, bruising, deformities always present associated with fractures. Then examine for the posture of the distal extremity as well, which is important. If this was a femur fracture, then probably we have to look at if the lower limb is severely in angulated position, which means definitely there is fracture because the patient is unable to bear weight, there is definite angulation, and then there is a massive swelling which is present over there as well. And then look for the skin color. For example, if there is a large hematoma formation over some area, then this may be changes in the skin color as well. So that will all this skin color, swelling, bruising, deformity, examining the posture of distal limb would point out whether probably there is fracture present or not. Now when you're continuing with the local signs, after looking at this, then comes the feel. What do we feel for? We feel for injured part are gently palpated. Gentle movement would elicit a severe pain, and that will denote probably that there is underlying fracture present as well. We have to feel for the vascular and peripheral nerves anomalies as well, especially if in the previous slide you saw a picture probably with open femur fracture. In that case, the first and foremost when we are feeling, we have to feel for the distal pulses. You have to look for the distal neurovascular examination as well, that what else could be injured along with this kind of a high energy trauma. And examine the spine and pelvis as well. The rule is generally is that you examine the one joint above and one joint below. If it's probably the shaft of femur or it's the neck of femur fracture, then you also go for the pelvis and spine, and also examine the knee as well, because there may be associated fractures as well. In case of usually shaft of femur fracture, 30% fractures are missed which are associated with the shaft of femur fracture, and they're usually associated neck of femur fractures. So whenever you see a shaft of femur fracture, we must also examine the patient and look for it associated neck of fracture as well, because there's always a high energy trauma and there's secondary injuries which are usually missed. Now once we're done the look, we have done the feel, then we go for the move. Move is to go for the press them gradually. The crepitus and abdominal movements usually denotes a fracture. If you move the joint, so one is to understand that we have to go and move the joint distal to it as well. And if the distal movement is highly painful, this means definitely there is some degree of fracture as well. But definitive diagnosis can be made only on X-rays. And X-rays is called as rule of twos. It's very important to remember. For example, as I told you, if the patient has presented with a shaft of femur fracture, there is thigh swelling, there's definitely pain, patient is in pain, and there's limb deformity. And yes, you are suspecting there's a closed injury of the shaft of femur. And you get an X-ray and probably it shows that there's shaft of femur fracture. Still, you should be getting X-rays which also show the knee joint as well as the hip joint, because there may be associated distal shaft of femur fracture, a knee fracture, a patella fracture, or they may be associated with the neck of femur or pelvic fractures as well. So it's called as two views. Get AP and lateral view. See the fracture from two angles, which is important so that you can understand and make up the 3D problem you have which you're facing. Because then in an AP view, you will only see what happens in the mediolateral plane. But when you are viewing it from the lateral view, you also understand what's happening in the anterior posterior way. If there is translation, is only medial lateral translation, or there is actually posterior anterior translation as well. So that is how it's going to help to the two views are going to help that. And usually two views are always taken, that is anterior posterior and lateral views. And the two joints. Why two joints? Because one joint above and one joint below is a mandatory thing. There may be associated injuries as well. So we have to look at the associated injuries as joint above and joint below. The fracture should be included. So if it's a femur fracture, a shaft of femur fracture, we must get X-rays which show the knee as well as the hip joint. Now coming to the two limbs. Usually this is kind of a scenario in case a child comes to you and complains of an elbow pain, and you're suspecting supracondylar undisplaced fracture. In that case, sometimes in children there is mild degree of swelling. It's very difficult to make it up whether there's associated fracture present or not. So you can get another opposite elbow X-ray as well, so just to know whether this is whether this is a fracture or not. So the first rule of two means two views, that is AP and lateral, two joints, one above and one below. And two limbs means you sometimes have to get the X-ray of the opposite limb just for the sake of comparison. Then coming to the two injuries, which is important, because whenever we are having a neck of femur fracture or shaft of femur fracture, we may be having a pelvis as well as spine involvement. So sometimes when we are getting a pelvis X-ray, we should get lower spine X-ray because they may be involved as well. And then two occasions means there are two injuries in which the X-ray may be very much normal. For example, in case of a stress fracture, because we will be doing the X-ray is normal, then we may have to get an MRI. And the other is the Pfizer injuries. Although some Saltines types actually do show up on X-ray, for example, 1, 2, or 3 type. But what happens is, for example, in case of a Saltines type 5 injury, which is crushed kind of injury, in which the X-ray may be absolutely normal, and once the child develops a deformity, we may know probably the patient had this kind of injury. So these kind of stress fractures or fission injuries, we have to scrutinize x-rays very carefully, and then we have to combine the x-ray along with our clinical findings to judge whether this kind of this is a stress fracture or a fission injury present or not. So special imaging, sometimes x-rays are not enough. So what are the different options we have is CT. Sometimes CT is needed because, for example, patient may be having some kind of an osteoblastoma or osteoidosteoma. Other patient may be having osteomyelitis, in which there is sequestrum and other problems may be associated. In this case, this will not appear well on X-ray, and we may need to get a CT for that. For example, patient may be suffering from stress fractures. Patient may be having some kind of a lytic lesion, and we need to assess whether this lytic lesion has spread into soft tissues or not. Then probably for that reason, MRI is the choice of option along with the X-rays. We may be requiring radioisotope scanning, the bone scans, which could be in form of to assess whether if that lesion, which is whether it's hot or cold lesion, and if it is present, is there any other multiple lesions present in the body or not. And if there are multiple lesions, which could be the case in case of multiple myeloma. And coming to the ultrasound, maybe it's required sometimes for the joint assessment, especially when there is synovitis or septic arthritis, then the joint swelling, swollen, there may be excessive amount of fluid which is present in the joint, and ultrasound guided aspiration may be required to diagnose whether it is septic arthritis or synovitis or not. So we may be requiring associated injuries along with the X-rays. So how to describe the shape of a fracture? It could be a simple transverse fracture, that is a straight line. This could be slow to join. Usually why? Because unless the mechanism, both ends of the bone are not completely opposed, this usually is slow to join. This could be spiral fracture, in which there is a twisting type of injury, although problem of this increased fracture line, but large contact surface area usually results in joints more rapidly, and there is relatively progressive healing. Then there could be comminuted fracture, which is often slow to join. Why? Because there is multiple pieces, and some pieces may have a periosteal blood supply may not be intact, and there may usually lead to non-union. Usually associated with more severe soft tissue damage as well, and likely to be unstable. Now coming to the displacement of fractures, there are 4 components which needs to be assessed. Usually whether the translation is there or not, which could be in either mediolateral and anterior posterior plane, which is backwards, forwards, or sideways. Is there any angulation present or not, which could be in any direction, but usually in the mediolateral plane or anterior posterior plane. The distal segment only angulates. And there will be rotation. The bones may be very much straight, but may be rotated on their own axis. This could lead to longitudinal bone axis rotational deformity. Or there may be a leg length discrepancy. For example, there is overriding the 2 fragments, which may lead to limb shortening. In this section, we have briefly gone how to diagnose the patient with a fracture. Starts with there is a history and examination. History is associated with either the history of fall or history of trauma or RTA, and then usually when you come to examination, you start by looking at the bone which is involved, or joint which is involved. There may be associated with swelling, erythema, there may be bruising, and there may be some degree of angulation or present as well. You feel for it, you feel for the crepitus, you feel for the pain, and you try to feel for the bone as well. And then once the feeling is done, then comes the moving the distal and proximal joint usually results in severe pain. This may be associated with limb length discrepancy. And we are feeling for it, we also go for examination of the neurovascular bundle, which is of utmost important. That's all. Thank you very much. Keep watching sqadia.com.